Hello, this is Caitlin Alexander presenting today a little bit of an intro about the um, design and implementation of a community-based pharmacy residency. This is a great introduction for preceptors to our program, and we'll go through different steps in designing the program. The program, just to be clear, our residency program has been designed. This is just to give you an idea of the different pieces and components and sort of the reasoning why behind what we're doing. This program is actually taken and is an abridged version of one that was given by APHA and was developed by these folks here on the slide. But I'm just going to go through some, again, abbreviated version and some key points. So kind of an introduction to precepting PGY1 community residents. So a couple of important concepts to cover. First, keep in mind that pharmacy residencies are both education and training programs. These graduates are licensed, they're able to go out and get entry-level positions, and so they are really giving a year of their time to us in order for us to help guide and develop them to be better practitioners and to be eligible for different careers should they choose in the future, or to be able to utilize certain skills more quickly. In general, a year of residency training is equivalent to about 3 to 5 years of work experience, and so it's not to say that by doing a residency there's something special that you couldn't learn on the job. That's not necessarily true. Where a residency is beneficial is it really allows you protected time to hone certain skills that otherwise you may have to put on the back burner because of other components of your job. The other nice thing about residency is because it's a learning program, you're given time dedicated to explore new areas. And we're going to talk a lot about the comparison between residency programs and other formal curricula just because of the education portion. So the goal of a residency is to produce consistent graduates. We want any person who goes through our residency program to come out on the back end being able to have the same sort of level of competency in different areas. And so to do that, the program has to be well designed, it has to be appropriately implemented, and then kind of go through quality improvement just to make sure that we're meeting the outcomes that we hope to set. So again, if we're comparing a residency program to traditionally what you find in academia, the ones highlighted here are the most relevant. So when you go through a curriculum, you take courses. The equivalent in residency would be learning experiences. So each learning experience has its own preceptor, which would be similar to the instructor. It has its own assignments and activities, which just like in academia would sort of help compose the grade, and the final grade would really be based off of sort of those cumulative final exams, and how we would evaluate a resident would be through summative evaluations at the end of a learning experience. So when we look at curricular design, you want to always kind of start with the end in mind. So what are the desired outcomes? What are we hoping to produce? And from there we build content. We identify opportunities for teaching and learning. We figure out how we're going to assess that learning, and then we figure out how we're going to evaluate our program to sort of cycle back and close the loop. It's important to know that we apply this curricular approach to residency training for lots of different reasons. One, it helps facilitate structure to the program. And that's something that's appreciated both by the resident and by the preceptors who are going through the program. There's no surprises. You know what to expect. Just like I mentioned before, having that true curriculum allows us to have consistent graduates. The other nice thing is that we're looking for is because these are licensed practitioners, we really want to progress that learner to independence. So unlike a student where they're always going to be still under your license as a preceptor or practitioner, a resident is able to practice independently, and at the end of the year that's really what we want. Trying to see if there's anything else. This model is very consistent with what they use in graduate medical education for our colleagues in medicine. So many people who are not in academia may not be familiar with this, but Bloom's taxonomy is a level of learning. It's a way to describe how you apply information. At the very, very bottom of the pyramid, you can see on the left is a slightly older version, and on the right is a newer version, but they essentially say the same things. So when you first learn something, typically the easiest way to verify that you've learned it is just rote memorization. So can you remember? And that's a measure of your knowledge. But then over time, it's can you apply what you've learned? Do you understand why? Can you apply it and then analyze the results? Can you apply it, analyze the results, and evaluate how well that knowledge or how well that implementation went, all the way up to creating something utilizing that baseline knowledge. And so really where we're focusing in residency is those higher levels of learning. In the PharmD education, we are definitely utilizing some of that knowledge and remembering at the bottom of the pyramid. A lot of our multiple choice questions that we use in examinations just ask students to recall information. And then as they go on to experiential learning, especially in APPEs, you'll see that application of knowledge. Really with residency, we're starting an application and we're building up just because we're coming out with a licensed practitioner as opposed to a student who is still practicing under someone else's license. When you look at our accreditation standards, which we have, community pharmacy residency programs are accredited by ASHP and APHA jointly, and they put out a particular curriculum that all programs need to meet, again for that kind of consistent product, so that anyone who goes through a community residency goes through the same training experiences more or less. And it's going to vary by practice site, but it gives a little bit of consistency. So the way they outline the different standards that we are to meet is they start with competencies. There are 4 competencies, which we'll talk about here in a minute, and those are really broad capabilities that can be demonstrated by the residents upon completion of the program. They're sort of buckets or categories of skills. Under the competencies are goals, which are specific abilities that unfortunately are not necessarily measurable. So they're a little more detailed, but not quite detailed enough for you to specifically be able to say, yes, that resident absolutely can do that ability. Objectives, on the other hand, are very specific, observable, measurable behaviors, and that's what we evaluate based off of. And to figure out what the resident needs to do to meet the objective, we design specific assignments and activities. And what I've done is help create those using activities that you already do as part of your daily routine in practice. Criteria kind of fall in the middle, so it may be attributes of that behavior that help you to think through whether or not a resident is achieving the objective. Sort of supplementary. So here's some examples just to kind of give folks an idea. And so this has an objective on the far left, a cognitive level, which is that Bloom's taxonomy level, so the level at which they're applying their knowledge, and then the activities that would contribute to evaluating that objective. So let's look at the second one down there. So the objective would be to prepare and dispense medications. That's an application of knowledge and skill. But the specific activity might be something like demonstrate the ability to perform the functions and responsibilities of a dispensing pharmacist by serving as the primary dispensing pharmacist from 8 to 5 every Friday. That's something that's very specific, so the resident knows exactly what they need to do. The evaluator knows exactly what they're referencing when they go to evaluate that objective. When we go to implement a quality program, it's really a collaborative effort. So it's important to me as the residency program director that I get buy-in from all the preceptors of what's reasonable, of what activities are appropriate. and we kind of build that infrastructure. Now it's going to take time. We're not going to get it right the first time. We'll probably have to go back and revise and change even as the year's going on, and that's okay. That continuous quality improvement is important, but really having a good framework allows us to guarantee that consistency. And ultimately what we're hoping for is full accreditation, because accreditation really is that quality seal of approval for not only employers of our residency graduates, but also applicants to our residency in the future. This systematic approach, again, just to make sure we've hammered this hard enough, is that we're really having graduates that are having defined and consistent outcomes, and that's what that systematic process really reinforces, that it's very consistent across the board. Okay, so the first step when you're looking at designing your residency is figuring out what your end product is. So what are we trying to produce? If you look in the standards and compare a postgraduate training or postgraduate trainee to a PharmD graduate, really we're looking at a pharmacist with additional application of knowledge, skills, and ability who also has enhanced competencies and proficiencies in patient care, as opposed to a PharmD graduate that's more at an entry level. So it's just a little more advanced. When we look at purpose of a residency, this is provided by the accreditors. Basically, it's to build upon the PharmD education to develop community-based pharmacy practitioners with diverse patient care, leadership, and education skills who are then able to pursue higher levels of training like certification and a second-year residency should they choose, but very uniform. Now, if you remember when we talked about the curriculum, we mentioned competencies, and these are the 4 required competency areas where all of our training is going to focus. Those include patient care, leadership and management, the advancement of community-based practice and improving patient care, and teaching, education, and dissemination of knowledge. Now, the accreditors actually specify that at least 66% of the resident's time has to be spent in patient care scenarios. The remainder part, so competency areas 2, 3, and 4 listed there, combined account for the other 34% in whichever breakdown the program deems appropriate. So once we have that understanding of where we're going to spread the resident's time, we go in to build those courses or learning experiences. Now there are 2 different types, core and elective. The core learning experiences for our residency program are listed here, and these have been slightly changed just in terms of the breakdown of when the different sections are occurring. But orientation is basically a 4-week experience in the month of July just to get the resident sort of up to speed on everything. Patient-centered dispensing is a required component. It has a little bit of patient care, a little bit of management in with it. The majority of the resident's time will be spent under medication management services, and this is sort of a catch-all experience for any advanced patient care service. It could be MTM, it could be medication synchronization, health outreach, education programs, immunizations, coaching programs, so kind of the sky's the limit. Collaborative care is a longitudinal experience that happens over the course of the year, and it's really focused on one particular advanced patient care program. For Boone Drug, for example, that patient care program is Julie Scott's practice at a local family medicine clinic. And so the resident would spend a half day to 2 half days a week with Julie in that collaborative environment with other healthcare providers. Now for other sites, it may not be an interprofessional setting. It may be a collaboration with an assisted care facility or a collaboration with the health department. But it's heavily patient care focused. The remaining experiences round out the more non-patient care focused areas of training. So the resident will be involved in teaching. They'll have a research project. they'll go through a management experience, and they'll also have a focus in leadership, and that's specifically related to professional organization engagement. Now the residents also get to pick an elective, and here are some options of electives that we've sort of floated, but the resident's able to select one of those, and then things are sort of adjusted accordingly to allow that to fit into their schedule. Here's what the year-long schedule would look like. So as you can see, most things sort of happen longitudinally over the year, and it's a balancing act, and that's actually a great learning experience in and of itself for the resident to figure out how to manage their time and how to get everything done and still get a really diverse experience. So once we've gone through and developed which learning experiences we have, then we have to actually go in and build a description, a syllabus for that learning experience. And it basically describes what the resident will do, what kind of activities they'll be engaged in, and also how they'll be evaluated. If you have any questions about the learning experience description for the learning experience that you may be associated with, I'd be happy to provide those to you. They're all drafted up. Okay, so we've developed this curriculum, we've looked at the accreditation standards, now we have to implement it. And this is where precepting comes in, and there's some specific things you need to do to be a really effective preceptor. One thing is to be considerate of the learner's experience. So if we start on the left here with the learning pyramid, at first when anyone is put into a new environment, we're really focusing on foundational knowledge and skills. So what do they need to know to be able to participate and gain independence? Then as they learn that, they're able to apply, and ultimately they're able to integrate that knowledge with the application and build into those creation and evaluation sort of learning levels. So how as a preceptor do you facilitate that growth? Well, there's 4 key roles, and this is really important. I need everybody to try to remember this. 4 key roles that you can do as a preceptor to help guide up the learner up to a more independent level. So the first one is direct instruction. If you think about your students, let's take your introductory students, those first-year students who come more for observation. If they are watching you counsel a patient, and eventually you're like, okay, let's have you try. You may need to instruct them specifically on what to tell the patient. So if it's a patient coming in for an antibiotic, you may need to remind them to, make sure you tell them to take it with food. Make sure you tell them they need to finish the entire course, even if they're feeling better. Make sure you tell them, whatever other things. Don't forget to ask if they have questions. You're really prompting them along. Then you may model for the student. So, okay, why don't you watch me do a counseling session and watch me do a couple, kind of get the hang of what I'm doing, and then you can go try. That's more modeling. Then you have coaching, which is where you say, especially your more advanced learners now, okay, you've watched me counsel a couple of times, I've seen you do it. How about you go counsel, and I'm going to sort of watch you from over here, and when you're done, I'll come back and give you feedback. So you're sort of allowing them to do it independently, but still keeping a close eye on how they're doing. And then facilitation is, okay, you go counsel every single patient that comes in, and when you have questions, you come talk to me. It's a very hands-off approach. It's after you've verified that they have the skills and are able to apply what they know, and you're confident in their abilities. With a resident, certain skills are going to move very, very quickly to facilitation. Some may take a little more time, especially more advanced things, but really we want to sort of keep those 4 roles in mind as we go through. Every person's going to be different in terms of their competence and abilities, but we really do want to remind ourselves that we're pushing them towards independence. Here's a couple examples. So in this scenario, it's fall, it's flu season, and you have a resident who took a training program as a student and had to administer over 100 flu shots. You've not seen this person give a flu shot, but you're trying to figure out what preceptor role to do first. So I think you could look at this a couple different ways. As far as direct instruction, if this person has given over 100 flu shots, I think we're probably safe to say that we don't need to do any direct instruction. Some people may feel more comfortable modeling one. Here's how I do it, just in case the person has any questions. You might ask the resident, well, do you want to watch one with me, or and kind of get their feel for their confidence level. Some people think that they can just coach them from the get-go. I don't know that there is a right or wrong here, but I probably wouldn't start with just facilitation first. We want to make sure that we've at least assessed that that their skills are appropriate. Just because they've given 100 flu shots in the past doesn't mean they're doing it right. This example is similar. So it's late March, so towards the end of the residency year, and the resident has been working with you in a diabetes management clinic 2 days a week just since the beginning of the month, so about 3 or 4 weeks. You've seen patients together, you always discuss each case after the visit, you sign all their documentation, you're pretty confident that the resident knows what's going on with the clinic and with diabetes care. The resident wants to start seeing patients independently, so what role should you take? It might be good to figure out what role you're already at, and it seems like right now you've been modeling, so you're seeing patients together and discuss, so it's a little bit of coaching. So I'd say you could probably go between a little bit of coaching from a distance and at a less frequent intervention level and facilitating. I think this resident's definitely ready to jump in and probably do it on their own. And I should say, when we talk about precepting, it's okay to make the resident a little uncomfortable. A little bit of being pushed out of the nest and being forced to fly isn't always a bad thing. You just want to make sure that they know that they can check in if they are not comfortable, and that you've at least evaluated them up front. There's nothing worse than day one saying, okay, good luck, go on, because you have no idea what baseline is. So precepting is a little bit of a balance. You want to challenge them, but you also just can't send them out to do, whatever. Okay, so now we've implemented the program. We've precepted and taught. We need to figure out how to assess performance. And one of the most critical roles that a preceptor has is to provide feedback. It's really an essential to help the learner grow and develop, and it lets them know whether or not they're meeting expectations. You always want to inform the resident whether or not or what your expectations of progress are. So where do you want them by X time in the rotation? Where do you want them by the end of the rotation? You really want to reinforce when you give feedback what they're doing well and what they can improve on. Everybody is always going to have something to improve on, even the most high achieving residents. And it's always good to have that balance of needs improvement and things that they're proficient at. We also have to, as part of our training program, figure out how to train residents to be able to self-evaluate themselves, because that's just a really critical skill to have as a practitioner. So as a preceptor, your role is to provide them with feedback that can be used right now, as well as to foster independence. And when we talk about fostering independence, there's very structured learning environments where they're getting lots of feedback and little self-assessment, whereas independent learners, once they get to independence, they're self-assessing much more and receiving very little feedback. So usually we'd start with more feedback, and as they gain proficiency, we can really back off. So what are the deliverables? What do we have to assess? Well, as I mentioned, the resident has to perform self-reflection, and then there's formative assessment and summative assessment. So formative feedback is that sort of informal on-the-fly feedback that you provide based on skills. And again, it's a balance of strengths and weaknesses. The accreditation standards require that preceptors provide ongoing, frequent, immediate, specific, and constructive feedback to residents about how they're progressing and how they can improve. and they adjust the learning activities in response for sort of what they see on a day-to-day basis. Here's some examples of formative assessments. So it may just be observing and then talking about performance. That's probably what, at a practice site, what you'll see the most. It may also be a completion of a specific assignment and then comparing that with what a preceptor would have done. So why formative? I always tell students on rotation, when you get the grade at the end of the month, it should not be a surprise. Nothing in your evaluation should be a surprise. We should have talked about it already. And talking about it is that formative piece. So it allows them to improve their performance. It allows them to know whether or not they're achieving. And really it allows the acceleration of learning because they're going to build much more quickly. Ways to provide formative feedback, it kind of depends on your preference. It can be written, it can be verbal. I don't particularly have a preference. Formal or informal also don't have a preference, but one thing it is important to do is criteria-based. And this is true of summative evaluations too. So you want to make sure that whatever feedback you give, it's not like, oh, you're doing a great job, or oh, you have a great attitude. It's something like, the way you interact with patients is great because you build really good rapport. Patients feel very comfortable with you, and the information that you give is very relevant and patient-oriented. Now, where you could improve is making sure that you're appropriately detailed when you're dealing with the providers, because sometimes your recommendations lack a little bit of specificity. So that's very criteria-based. It's very specific. You also want to make sure when you give feedback that it's FAST, and here's the acronym, that it's frequent, accurate, specific, and timely. You don't want to give feedback 2 days after something's happened because the resident's not going to remember, and likely you're going to forget to even give that feedback anyway. So give it right when you see it. Summative assessments, on the other hand, are the ones that take place at the end of a rotation. They usually are compared against some sort of benchmark, maybe a previous performance, and they are more formal. So here it would be through an evaluation. And basically, at the end of each experience, you have to document their progress towards the goals and objectives assigned to the learning experience. So all those things that we talked about back in the accreditation standards related to those competency areas. The other thing that's important is that if more than one preceptor is assigned to a learning experience, all the preceptors have to give input. So make sure your voice is heard. If you are not assigned to a learning experience but still interact with the resident somewhat, you may want to make sure you give it to whoever the primary preceptor is. After you fill it out, it's important that the preceptor and resident discuss the evaluation, and then the evaluations will actually feed into a large plan that I will manage as the program director that helps sort of allow us to tailor the resident's growth. So what does it look like when you fill out these summative assessments? Well, this will actually take place in a software system called Pharm Academic. And this is an example of a screenshot. So you'll see there that the goal is listed and then the objective. And the preceptor is going to assess the objective based on that scale there, either needs improvement, satisfactory progress, achieved, or not applicable. Now for the beginning part of the residency, a lot of them are going to say needs improvement, and that's okay. That's what we would expect. They're not proficient. Some things people will have achieved or have satisfactory progress right off the bat, but a lot of skills will need improvement just because this person is learning and it's new. Once a objective is achieved, it will show as green. If all objectives under a goal are achieved, then the goal likely will show as green as well. And then you always want to make sure you put comments. We've tried to keep the assessments fairly short so that you can provide those comments, and that again they are criteria based. Now let's say when you're looking at an objective, you're not really sure what it's supposed to be evaluating. There's two buttons off to the side there in blue. One says criteria, and so this is going to help guide you through some of the attributes of that behavior. And if that's still not helping, you can click on the button that says Activities. And these come directly from the learning experience description syllabi, if you will. And they are what the resident was supposed to have completed to help you evaluate that objective for your learning experience. And so that's just two things that are meant to be helpful for you. Okay, rounding things out. So you've given them feedback. Tracking progress is really something that I will do as a program director, but really what I'm interested in is making sure that the residents are moving through the program at a rate where they're able to achieve the outcomes that we have set. And we look at it through the lens of a professional development plan. The residents will also maintain some sort of portfolio where they document all the document sort of proof that they've completed the different activities. And preceptors and myself as the program director will sort of review and monitor that work routinely. The last thing we need to do is really evaluate the program to make sure that it's good quality. And you may not realize this, but preceptors actually need to be qualified to make sure that we have the right people providing the education. And so there's some forms that I may need to have you fill out. And we also have preceptors participate in both preceptor development, similar to this session, and creation of a preceptor development plan to help them identify their own learning needs related to instruction in the residency program. This is an example of our preceptor qualification information. We have checklists just to make sure that people are, again, meeting the standards that we'd had set. But that's all reviewed by myself. And then we do have a quality improvement discussion at the end of each residency year just to look for ways to enhance the program. With that, I thank you for listening along. If you have any questions, feel free to email me or talk to your site coordinator, who hopefully can help clarify anything that's been have any confusion. And again, thank you so much for your participation and contributions to resident learning.